Hello everyone, it's my pleasure and great honor to introduce myself to you. My name is Professor Dr. Ossama El-Khouly. I'm a professor of psychiatry at Alexandria University, and today we'll discuss one of the most common psychiatric disorder you will see if you are not practicing psychiatry. So whatever your specialty will be, about 30 to 40% of your patients will come to your clinic without any evident medical cause for their complaint. In these situations, you will find yourself like confused for a little because all the investigations are negative, all the medical records are negative, all the examination is negative, but the patient is complaining. So either you consider this patient is faking the symptoms, and this is what we call malingering, or try to manipulate the situation to be a patient to having a patient rule. That's what we call factitious, and we'll discuss this later. And most importantly, although you are not a psychiatrist, whatever your specialty will be, you should consider this diagnosis, which we call somatizations. What the meaning of somatizations? Soma means body, and somatizations means body disorders or body symptoms is the sole manifestation of such disorder without any evident medical cause. The main cause is psychological. So the symptoms has a physical abnormality or physical appearance, but the main cause of these symptoms is psychological cause. And symptoms this is the third most important part of the definition, that the symptoms are not under the patient conscious control. So he is not responsible for such symptoms. He is not faking the symptoms. And that's what is the difference between malingering and factitious on one hand and somatization on the other hand. In somatization, it's happened under the patient, it did not happen under, do not happen under the patient conscious control. It's happened unconsciously. So the patient has no role in production of such symptoms. This is the classification of such disorder. We'll discuss each one separately, and then we'll discuss the newer classifications, how they rechange these names. So in the DSM-4 classifications, this is the old classification, they classify somatization disorder under somatoform or somatizations, conversion, pain disorder, body dysmorphic disorder, hypochondriasis, and undifferentiated somatoform disorder and somatoform disorder not otherwise specified. We'll discuss each one of them separately. What is the somatization disorder? In the recent classifications, the name have been changed from somatizations into somatic symptom disorder. And in this disorder, the patient coming to you and complaining of everything. So a patient come to you and say, okay, I have a headache, I have a back pain, neck pain, abdominal pain, I have palpitations, I have constipation, I have a low sexual desires and low sexual potency, I have difficulty in breathing, and so you find yourself confused where I will start. So an unexperienced physicians, what they will do, they will ask for investigation for everything, and this is a major help because the payment for the investigation is from the patient's own money, and when he return back, you will find all the investigation is free. So what will happen? The doctor will starting to give a symptomatic therapy. So you have headache, this is the treatment for headache. You have back pain, this is the treatment for back pain. And the major issue also that the patients still have no response to this medication, so this symptomatic therapy. So now if you are not attending this lecture, you will not find yourself able to deal with such patient. Somatic symptom disorder characterized by multiple somatic complaints requiring medical attentions but not associated with any physical disorder. Prevalence from 4 to 6%, maybe high as 15%, and I think in our country it reached to 20 to 30%, because in all developing country and in lower socioeconomic class person, Usually somatization is much higher than any other psychiatric disorder, because it is easy to an uneducated woman or uneducated person to say I am physically sick, rather than to say I am psychologically sick. He may be attacked by the culture, by the family, by the religious rules. So it's easier to them to say they are physically sick, so they will not have this attack, or they have this criticism. It's age between 20 to 30. It's okay about 3% of the medical students, and we all know about when you attend a lecture and then the presenter is very good and the doctor is very good, so after the lecture you feel that all the disorder he's talking about is in yourself, and that's what we call medical student syndrome. And this is very common in medical student. As we said, it's typically in unmarried lower socioeconomic class patients and living in rural area. And this is the DSM-4, this is the DSM-5 criteria actually of the somatic symptom disorder. Somatic symptoms: one or more excessive thoughts and feeling related to such somatic symptoms, persistent thought about the seriousness of such symptoms, and persistent high level of anxiety about the health, and excessive time and energy devoted for these symptoms or health concern. Typically it's more than 6 month durations, maybe with pain and maybe without pain, like maybe they have just dyspnea, sexual drives, GIT upset, and most of them coming with pain, and specify either it's persistence or not. Of course, if you find the symptoms like this, you need to be sure that this is not a medical syndrome. We have a lot of medical syndrome or physical syndromes, which is presented by multiple physical symptoms. So one of the most important issue, you should exclude the etiology of somatizations in comparison with other medical disorder like endocrinopathy, myasthenia, multiple sclerosis, systemic lupus erythematosus, and so on. So these all are medical disorder presented by multiple physical complaints. So if you are suspecting by this physical disorder, you should exclude by investigations. And of course, as we said, it should be differentiated from malingering and factitious, as we said before, in which the patient are faking the symptoms or simulating the symptoms, it's happened under their conscious control in factitious and malingering. It's usually chronic. It have exacerbations with waxing and waning. Maybe each episode may last for months or years. Usually it's precipitated by psychological stress, and the symptoms are usually associated or exacerbated or increased under psychological trauma. If it is high socioeconomic class, if there is a sudden onset and absence of personality and the absence of any other medical conditions, this is a good prognostic factors. Most of the children, because sometimes it could happen in children, they are recovered by adulthood or adolescence. Very important that if you are a physician and you are faced with such patients, it's very important not to attack the patients by some complaint or some comments like it's all in your head, you have nothing, you have no disorder, you are just faking the symptoms, you are not seeing the reality. Some doctors saying a lot of stuff which is like it's not a good way for dealing with such patients. The term which I like that in this fourth in this part, understand the symptoms as the measure or a method for emotional communications. So these patients want to say something, but they cannot be able to present it from the psychological point of view immediately, directly. I am depressed, I am anxious, I hate my father, I hate my mother, and I hate so on, so on. These patients need to talk, but because they are not able to talk, because there is a lot of stuff happening in their culture or in their family or this stuff. So they try to express the symptoms in the form of psychology or in the form of physical symptoms. They try to express their psychological stress in the form of physical symptoms. So it's very important that you should open for the communications with such patients and consider these symptoms as a method for emotional communications. He need help, he seek for help. And you are not obligated to refer him to the psychiatrist. You are the primary care physician or treatment physician, and see they start treatment with them. Because another issue that some physicians, the patient come to them and say, oh, you are a psychiatric patient, go to hell, go to the psychiatrist, you are mad. So patients will not accept that, because the only thing which I'm complaining are physical symptoms. So why you will refer me to a psychiatrist? So you should be able to deal primarily with such patients, just to correct the ideas, to listen to him, to calm him, to support him, to explain to him that this is due to the psychological stress. And usually I face with this problem actually. When the patient even come to me and he say, okay, I have a headache and back pain and abdominal pain and chest pain and whatever, and dyspnea and orthopnea and whatever, and you say this is related to psychiatry, are you sure this is how it's happened? I have just a very easy comment that I usually say, do you know that the psychological stress can cause stroke? Do you know that the psychological stress can cause diabetes? So, do you know that psychological stress can cause hypertension, for example? You say, yes, I know that. One of my family had this problem. And I usually say, if something can cause diabetes and hypertension and death and stroke, it's easy to cause some dyspnea or chest pain. So in this situation, the patients, although this is two different, completely different situations, but in this situation they have no hypertension, no diabetes, they have no physical symptoms, but just the explanation to them that the psychological stress is a major issue in production of the symptoms, this helps them to be calmed and to be relaxed for a while, and to relieve the anxiety associated, as we see in the DSM-5 criteria, and anxiety and worry and excessive thoughts. This will be relieved because they don't find the cause for their symptoms. So when you explain to them that the cause is related to the psychological stress, they will starting to reshaping their thoughts and reshaping their minds, so they can correct what's happening, or you can arrange the thoughts in a good way to deal with it. Of course, you should exclude physical disorders, so physical examination is mandatory. Exclude also physical disorder if you look for the signs. If there is a sign of a physical disorder, so we are not dealing with somatization disorder, but if there is no signs, it's only symptoms, we should consider them in our somatoform disorder or somatization disorder in our clinical differentiation. Sometimes pharmacotherapy is helpful, and group therapy provides social support for such patients. A milder form of somatization disorder, which is called undifferentiated somatoform disorder, which the patient does not come with the multiple symptoms, it's only one or two symptoms, and this is very common. It's one of the best example for such disorder is irritable bowel syndrome. In irritable bowel syndrome, the patient come with the GIT symptom and that's it, but they have no multiple chest and abdominal and back and headache. No, just GIT, abscess, whatever the cause of diarrhea, constipation, or whatever, and so they have that's what we diagnose them with irritable bowel syndrome. Of course, irritable bowel syndrome have no physical abnormality, structural abnormality in the GIT, but the patient is complaining and the patient is suffering, and it's higher common, of course, from 30 to 100 times more prevalent than the full-blown picture of somatization disorder, and usually it's happened with depression and anxiety and personality, and in every psychological disease you could find some form of somatization with them. The second disorder, which we call illness and anxiety disorder, this is in the recent classification in the DSM-5. In DSM-4, the name was called hypochondriasis. What's hypochondriasis? If the patient believes that they have a serious illness, although there is no physical or laboratory or imaging sign for such this disorder or this abnormality. So in the era of COVID, for example, a lot of patients come just they have cough, or maybe they have fatigue, and come to the physicians, to the chest physicians or the GP and say, doctor, I feel I have COVID. Okay, let's do the CT chest, let's do the lab investigations, and they found nothing. But doctor, all the symptoms of COVID I have, all the symptoms of COVID, okay, but you don't have COVID. The patients cannot stop thinking that he have a COVID, and he deal with the situations that it's real, although it's not. There is no evidence that they have it. But the problem is such patients is obsessed more or less with the idea that they have a serious illness, particularly, let's say, sometimes it's malignancy. If they have a positive family history of malignancy, sometimes it's COVID in case of the era, and all the media is speaking about the COVID. So the patient is convinced that they have this disorder, and usually it's a major disorder, and usually it's a serious one with the very evident or very problem or bad problem in the prognosis. So they are convinced with that, and the convictions persist despite their negative laboratory test and assurance, and they are often addicted to the internet search about the illness. And usually you will find such patients, you will think that he know about the disorder which he is thinking about even more than you. He think about everything, and usually I have some patients come to me and say, oh, in 2021 in September there is a paper about such a disorder which you say it so and so and so, and I say I did not read this paper, and he is internet addict, or he is addict for the search for about this disorder. He is not usually addict about other disorders. It's not in the medical field. He is searching about the thing which he is worried about his illness or the illness under his mind or under his obsessive thoughts. And of course it's usually associated with anxiety and depression. And this is the DSM-5 criteria for illness and anxiety disorder. I said in DSM-4 it was called hypochondriasis. In DSM-5 it's called illness and anxiety, which because it's of course better than the hypochondrium or hypochondriasis. Hypochondriasis was not evidence because this is the area of the hypochondrium which is in behind or in the area of the liver, so it has no relations with this. I don't know why they name it like that. So in DSM-5 they correct the names to be more informative. They said it's illness and anxiety disorder because it's a disorder about an anxiety from illnesses, preoccupation of having or acquiring serious illness, somatic symptoms is present or may not present, and if it's present it's mild, and usually it's present to this medical illness. High level of anxiety about the health, high level of excessive related health related behavior, going to check a lot, going to try to do a lot of investigations and so on, or maladaptive avoidance, or maybe avoidance of the appointment and hospital because they are usually faking the trials, and I am sure I have COVID and they are bad, they cannot do their work good, so they usually either go a lot to physicians or avoiding to go to the physicians because they say that all physicians are bad. At least present for more than 6 months, and it's not related by, or it's not better explained by another medical disorder or another psychological disorder. And specify either care seeking, as we said, or care avoidance, care seeking type or care avoidant type. Peak between 20 and 30, chronic conditions. Of course, in comparison with the somatization disorder, hypochondriasis or illness and anxiety disorder have high prevalence in higher socioeconomic class, because these patients or this group, they are able to go to the internet and be able to search and buying magazines, medical magazines, and reading a lot. So it's higher in higher socioeconomic class. It's higher in prevalence. Usually, no reliable data about the prognosis, but it may have a good prognosis if they have treatment responsive anxiety, absence of personality, and absence of other psychological or medical conditions. Again, it should be done by the treating physicians, the treatment, and sometimes we require psychiatric involvement, and in this case you should explain to the patient first why they need the psychiatric involvement, because you have obsessive thoughts about such disorder. You should frequently do some physical examination to the patients to calm them and to support them, because if you don't put your hand on the patient to do examination, he will not feel calm. He feels that you are abandoned him, or you overlook his symptoms. Group therapy again provides social support. Other form of psychotherapy like CBT and hypnosis sometimes is useful, and pharmacotherapy like antidepressant or anti-anxiety if there is a presence of anxiety or depression. The third disorder, which it's the most common of these somatoform disorder, is called conversion disorder, and in recent classification is called functional neurological symptom disorder, because in this situation the patient comes to you with only neurological symptoms, but these neurological symptoms is not related to any neurological disorder. It's only related to the psychological stress, so it's functional. So it's functional because it's related to the psychological stress, and it's neurological symptoms because the symptoms happen only in a neurological form. And in the previous classification they called it a conversion, because it's just conversion of the psychological stress into physical symptoms. So this is the idea about conversions. It was a psychological stress, so the person cannot face this psychological stress, they changed it into into physical neurological symptoms. That's why they term the conversions. But the term of functional neurological symptom disorder, which was used in DSM-5, produce better explanations for how the form of the symptoms or how such disorder symptoms developed. It is disturbance of the body functions that does not conform with the current concept of central and physical nervous system. Like, by anyway, so the symptoms happen in the form of physical, but it's either it's only a neurological symptoms, either in the central nervous system or the peripheral nervous system. So a patient at the time of stress develop hemiparesis, for example. And when you go to the emergency, they do MRI and CT, they find nothing. When they do examination, the plantar reflexus is flexor, and there is no signs of asymmetry. Although the weakness is present, the patient cannot be able to walk. And when we discuss with the patient, it's only happen during stress, and when the stress is resolved, it can be resolved. So it appears like a stroke, it appears like hemiplegia, but it's not a hemiplegia. So it's a functional neurological symptoms, but it's not a true neurological symptom. It's due to the psychological stress, of course. One of the very important signs we find in a patient with a conversion disorder, the name in French, la pile indifférent, which means the patients appear in front of you like more calm and relaxed than what the situation should be. If I come with the hemiplegia, for example, to your clinic or to the emergency, I should be worried, but you will find the patients, maybe the family will be worried, but the patient is calm, actually, because he relieved the stress, which was the psychological stress which he facing, with the appearance of these neurological symptoms. Let's say a girl with her father, they in a fight and they are in quarrel or in something, and he said something and he hurt her in her face, so she start to lose her eyes or lose her vision. So what he will do, he will starting to calm her and try to help her whatever she wants, and that's why the stress is removed. So when she will come to the ophthalmology clinic, she will be more calm, because now my father is in my hand. And some patients will, or some persons will say, okay, she do it under her conscious control. No, it's not under her conscious control. It's unconscious, try to escape the situation, and that's the way he find that the escape is right and it's working. So he will do again and again. When any stress, the unconscious will say, okay, go away from such stress by doing or by producing such neurological symptoms. And usually there is a symbolic nature of the symptoms. If the person's going to his house and finds his wife cheating on him, what he will, and the conversion should happen now. He should have a psychological stress now, and so he would try to escape the situations. So what he will do? He will get blind. Actually, he will not get blind from the physical point of view, but the physical, or from the psychological, the psychological stress, asking the eye to stop working, or the area in the brain actually of the eye, the visual association area, it's not working. He will not see anything, because once he did not see anything, so nothing happened, and nothing will cause him stress. So everything is resolved. So there is usually a symbolic nature for such symptoms. Again, it's not under the patient conscious control. This is very important. You should not consider that these patients are faking the symptom. They are not faking. They are not. They actually don't know what to do in these stressful situations. Women are more frequently affected, of course, because of high emotionality. It's common in histrionic personality, and we usually collect some information about the conversion by sudden onset, symbolic nature, secondary gain from the symptoms, stress, and it's resolved by suggestions. These persons, the histrionic personality and persons with a lot of conversion symptoms, they are usually have high suggestibility. So giving them a pill and say now, or an infusion, and saying that this will correct the situations, you will feel calm and you feel relaxed, take a deep breath, and then starting to move your hand, for example, and just, it's a line, but just the suggestions give them help. And this is like usually the main customer for the traditional healer, because they usually give them some water or some pills or some whatever, some papers, and usually they resolve it, and they will be by high suggestibility they will be improved, and that's the way the traditional healer make their history and making their progress. Of course, it's higher in men, in women, higher in girls than boys, usually in the late childhood or early adulthood, rare before 10 and after 35, and usually if we say in any conversion, you suspect the conversion symptoms before 40, after 40, please consider physical etiology first. Don't consider conversions. Search 1 and 3 and 4 times about physical etiology before you consider conversions after age of 40, except if it's happened before 40. Yeah, like it's happening in all of his life. They have conversion symptoms happen with each stress. It's okay, but if it's the first time after 40 or 45, please consider physical symptoms or physical etiology. These physical symptoms or neurological symptoms as a physical etiology first, and search a lot before consider conversion disorder. There is some example for the conversion disorders, like there is a term called aesthesia apasia. It's like the term is the dancing movement, like a patient is coming to your clinic and he is dancing and he considers this is ataxia, but this is not ataxia. So the term the ataxia is only by moving in a wide gait. That's the only presentation of ataxia. But because they are not physicians, of course, so they consider that the dancing gait is ataxia. So he cannot walk, but he can dance, and that's why the term of the magical term of astasia apasia. The second example is pseudo seizures, as we said, the seizures which happen because of the etiological cause, not because of the epilepsy, and we can differentiate by some points in the history. There is no self-harm. In the pseudo seizures, there is no incontinence. There is happening in front of others. It's not happening alone, does not happen during sleep. Usually the pseudo seizures is long durations. If it's 1 hour or half an hour seizures and the patient is standing in front of you, of course it's pseudo seizures, because if 1 hour true fits related to epilepsy, it's called status epilepticus, and the patient's on a ventilator now, so it's not real to have a long durations of true seizures. So any long duration seizures, particularly if it has no consequences on the patient's mentality or consciousness, so of course you should consider pseudo seizures first. There is, again, we said the secondary gain, it's happening in front of others, does not happen during sleep. During sleep only what's happening is true seizures. Of course the symptoms could be in the form of sensory symptoms, or in the form of hysterical blindness or deafness or whatever. Again, usually the resolution happens spontaneously. Most important therapy is the relations of caring and confident therapist. So you need to listen to the patients, not underestimate their symptoms. Telling such patients that their symptoms are often make them worse. Of course, you need to understand their symptoms, again, as a methods of emotional communications. Sometimes relaxation therapy, behavioral therapy, hypnosis, anxiolytics, and psychoanalysis and insight-oriented psychotherapy are often used to explore the intrapsychic conflict. So this is the methods for treatment of conversion or functional neurological symptom disorder. The fourth or whatever is the body dysmorphic disorder. It's one of the common disorders in this era or in this century, because usually the persons or the patients, they are not satisfied by their face or their appearance or their look or their body shape, or they see imagined defect in their appearance or exaggerations of the present defect. So sometimes maybe my nose is a little big, but if I see it's a wholly big, it's a major big, so we have a problem, because it's not like that. So these persons, they are preoccupied with imagined defect in their appearance or excessive concern over a slight physical anomaly, like my eyebrow in one side, it's thicker than the other side. What's happening? I don't care. No, they care. They care a lot, and they find themselves they're like obsessed in this appearance. The distressing preoccupation may involve any part of the body, imagines or slight flow of the face, head, such as acne, scar, thinning hair, facial asymmetry, or excessive facial hair. All these minor defect or minor physical anomaly, they are highly concerned about it. Onset usually, of course, in adolescence, because this is the main time of considering the appearance. Many of them go to surgeons, dermatologists, plastic surgeons, and usually they are reluctant to seek a psychiatric treatment. And again, that's why in the start of my presentation I say these cases you will see a lot in your clinic, particularly if you are not a psychiatrist. Whatever your specialty will be, gynecologists, dermatologists, internal medicine, surgeons, whatever your specialty will be, you will see these patients a lot. almost about, as I said, 30% of your patients are actually from our patient as a psychiatrist. And please treat them. Don't send it to me. Don't send them to me. It's your patients. You should be able to primary caring with them. Patients with body dysmorphic disorder are more candidates for therapy or psychotherapy or even for surgery because they are unlikely to be satisfied with the result. They are usually seek that I'm not right, I'm not good, I'm not healthy, and so on. So this is the whole group of somatization disorder, and then we differentiate between them and two major issue or major disorders which is not related to the somatization disorder. It's just for differential diagnosis. One of them is called factitious disorder, where the symptoms is produced consciously. The symptoms is produced consciously and intentionally to motivated by the motivation to become a patient. It's happened in let's say in a person who is stopping medication to get sick, to go into the hospital, to receive money or to receive food and receive shelter. So he consciously and intentionally stopped his medications to go to the hospital. And some persons, like let's say a person in the street cutting their hand because they want to receive money from the people in the street. So they are consciously cutting their hand to go to outside and to become sick to receive financial support or financial compensations. So this is what we call primary gain, and it's not a secondary gain, it's not emotional gain, it's a primary gain, some physical gain, and the symptoms is produced consciously. So the symptoms are intentionally produced or fight. False information is given intentionally. The self-injurious behavior or simulated somatic complaint are done consciously, as I said, to assume a sick rule to obtain a caring that come with medical treatment, for example. And there is another, of course, the term of Munchausen syndrome was famous about the factitious illness. And there is factitious illness by proxy when the person is doing a sickness or a physical injury for the patient under their care, for a person under his care, to obtain the primary gain. Like, for example, a woman may harm their child or cutting one of his fingers to obtain money in the street. So that's what we call factitious by proxy. Someone making harm for person under his care to obtain primary compensations from government or from a hospital or from a person in the street or whatever. So that's what we call factitious by proxy. The second differential diagnosis from somatization disorder is malingering, which is the patient intentionally and obviously produce symptoms to obtain a compensations or avoidance of duty or obtaining of the drugs. And again, it's the conscious intentions of the production of the symptoms. The main difference between factitious and malingering, in malingering there is no harm. They don't harm themselves, they don't make a sickness in themselves, they just faking the symptoms. But in factitious, they do harm themselves by taking drugs or making injury, so they make a physical illness in themselves but intentionally producing this physical illness. As I mentioned before, the differentiate between somatizations in DSM-5 and DSM-4, it's explained in this on this slide. In the previous DSM-4, somatoform disorder was classified into somatization and pain disorder, just pain, multiple somatic pain. And in DSM-5, they combined both disorder in a one term, which is called complex somatic symptom disorder. Just because they said, okay, somatization should be a pain, could be a pain. And the hypochondriasis, it's the same, it was in DSM-4, they changed the term into illness and anxiety disorder. And conversion disorder, for example, which is we mentioned before, they changed the name into functional neurological disorder because they found it's more conclusive and more informative about the symptoms, because it's neurological symptom disorder presented by functional etiology. And the major issue also is body dysmorphic disorder has been removed from in the recent classification from the somatic symptom disorder and have been included in the obsessive spectrum disorder, because they said that the concern about the body shape, it's related to the it's obsessive in nature, so they include them into obsessive compulsive spectrum disorder. This is just a table to summarize what all we just talked about in these presentations. Complex somatic symptom disorder, somatic symptoms, excessive thoughts and feeling and behavior related to such somatic symptoms. And it does not have medical explanations, and pain could be included, not a separate diagnosis, as we mentioned, the change between DSM-4 and DSM-5. Illness and anxiety disorder, it was the term called hypochondriasis, so that's a new diagnosis in DSM-5, and it's the definition of unwarranted fear about a serious illness despite absence of any significant somatic symptoms. Functional neurological disorder or functional neurological symptom disorder, name changed from conversion, remove the criteria that the clinician established that the patient is not fighting the symptoms, remove the criteria that a psychological risk factor may be apparent, and emphasize of the importance of neurological testing. And it's defined by neurological symptoms, does not explained by medical disease. And malingering and factitious, we mentioned about them in the description, but it's not in the DSM-5, but it's just to summarize what malingering is and what factitious is. Malingering is intention faking of symptoms to gain from these symptoms, and this is malingering. And infectious, a physical symptom without evidence of gain from these symptoms, that the only gain that the sickness rule. So the only gain, there is not a primary gain, they not take immediate money, but to obtain a sickness rule so they can take the advantage from the culture or from the hospital or whatever. Many issue about treatment of somatization disorder. There is obstacle for the treatment of somatizing patients often follow the similar sequences, and expensive workup, no diagnosis, wear and tear on the clinician, and frustration from the patient. And the cost of treating patients who are somatizing is 9 times that treating patient who does not have one somatization. So to treat patients with diabetes alone, or treat patients with diabetes and somatizations, for example, it's 9 times more if they have diabetes and somatization than the patients who have diabetes alone, for example. Patients are usually sicker than the sick. The physical symptoms are exaggerated. Patients are usually have a poorer health than those who have a chronic medical condition. So you find the patients with somatization like he is dying from the physical symptoms, although there is no physical illness, for example. It rarely responds to treatment, and if they respond, it's short-lived. So this is the major obstacle for treatment for such patients. They are reluctant to change. You cannot give a suggestions for a somatizing patients. Challenge suggestions and somatize each treatment. Usually when we give a comment for the patients, try to forget the symptoms, try to redirect your thoughts. He usually cannot accept these suggestions. How I do that? It's suffering, I'm suffering, I'm in a big trouble. They are dramatically increase or decrease the recommendation of their own. They are often rarely complete the adequate trial of medications, usually take the drugs for 1 or 2 days and then they stop it. They exhaust the therapist repertoire and one physicians and move to the next. So they move from one physician to other, and each one is starting therapy from the beginning. One of the major area how to treat such patients is caring, not curing. The more the physician try to do, the more the symptoms will the patient require. So the clinician may be demoralized by the patient undoing physical concern and inability to find a cure, and complain that not enough is being done for him. The physician need to be realized that further attempt to treat such patients who are not reluctant to change, who are reluctant to change, will be counterproductive. So you need to try to help the patients, not to care the patients, or caring for the patient, not curing the patients. You need to help them how they find the solutions for their psychological stress or psychological problem, which that's how the physical symptoms will be resolved. Sometimes doing less may be the most effective therapy. You don't need to do something, you don't need to more to endoscopy or invasive surgery or more lab investigations or whatever. Just offering treatment just by listen and try to understand, as I said, the symptoms and the methods of emotional communications. Never do harm. And management need to be done by a single physician. Regular and pre-visit, and each visit you should do physical examinations. Look for the signs again rather than the symptoms. If there is a sign, you should be suspected about physical etiology. And finally, the understanding the symptoms as a method of emotional communications rather than a disease. Although physical illness must be ruled out, the workup should be limited. Avoid unnecessary investigation and unnecessary invasive investigation, particularly. Avoiding reinforcing the idea that the problem is only physical. So just by searching more and more on the physical etiology, this is reinforce the idea in the mind of the patient that the problem is physically. Discuss the diagnosis of somatization cautiously, telling the patients it's all in your head. It's not usually useful. Just the diagnosis should be discussed carefully and cautiously, and as I said before, just explaining how the psychological stress may causing physical harm for them. Usually it works good. Decrease the stigma. Remember that they are somatizing rather than psychologize. They are just try to express their emotions and their psychological stress, but in the form of physical term. Finally, it's very important to know that drugs is not a very important in this situation. The placebo is not usual technique, and somatic therapy or symptomatic therapy is not a useful technique. We need to explain the psychological aspect, try to correct the psychological aspect for such patients, try to help them to identify why the psychological stress making these symptoms, or how to resolve such psychological stress before considering how to resolve the physical symptoms. Because once the psychological stress will be removed, all the physical symptoms will be completely removed. And finally, I hope you are good, and I hope I did not elongate my presentation a lot. And it was a pleasure and a great honor to be with you today. And again, happy to listen for any question later on if we meet together. Thank you.